50% of dying persons who require that a decision be made about their health care lack the capacity to make that decision themselves. Therefore, it's prudent to plan ahead. In this module, I will address the reasons to plan for healthcare at the end of life, describe the mechanisms available for end-of-life planning, give advice for planners, and discuss advanced care planning policy in the United States. This information is current and accurate as of when the video was posted in 2015. But since this arena is rapidly changing, be sure to check with lawyers and healthcare providers for updates. Most people think about planning for the end of life in terms of completing a last will and testament and planning funeral services. But fewer think about planning the medical care they would like to receive in the last weeks and days of life. In the United States today, dying persons face a bewildering number of medical technologies and treatments. We have machines that can breathe for us, medications that maintain our blood pressure, and a variety of other interventions that can keep the body functioning almost indefinitely. But at what cost? In a financial sense, the cost is high. A quarter of annual Medicare spending goes to care for the 5% of patients who will die in that year. That's an average of over $33,000 per decedent. In terms of human suffering, the cost may be even higher. Despite the assistance of advanced treatment technologies, many people still experience uncomfortable symptoms such as nausea, pain, and shortness of breath in their final days of life. Sometimes these symptoms are the consequences of the treatments themselves. For example, cardiopulmonary resuscitation, or CPR, can leave patients with bruises, internal bleeding, and broken ribs. And many treatments inflict these harms while failing to appreciably improve the quality of life, much less return the patient to a healthy state. For instance, only 20% of hospitalized patients who undergo CPR will survive to be discharged, and rates are even lower for CPR that takes place outside of the hospital. This state of affairs would be acceptable if patients selected these treatments while aware of the costs and benefits. However, most patients are not informed consumers, or they don't have the autonomy to die in a way that's consistent with their own values and preferences. For example, over half of deaths occur in a hospital or nursing home, although the overwhelming majority of people wish to die at home. Fortunately, there are ways for patients to make their own decisions and for families to become strong advocates for their dying loved ones. Advanced care planning refers to the means, both formal and informal, of planning for end-of-life care. Informal planning is comprised simply of discussions. People who discuss their end-of-life care preferences with their healthcare providers and with their loved ones receive care that is more consistent with their wishes than people who do not hold conversations. These conversations can help doctors match patients' ideas about quality of life with treatments that deliver that quality of life. Further, conversations can help loved ones to direct doctors in the case that the patient becomes unable to speak for him or herself. However, conversations are not legally binding. Therefore, conversations should accompany legal means of planning. Formal legal plans are called advance directives and can take two forms. The first is a living will. A living will is a document that goes into effect only if a patient is unable to make and express a decision at the time of care delivery. The living will describes the treatments a patient would or would not want to receive if incapacitated in a particular condition. For instance, a person may not want to be placed on a ventilator if he or she has advanced dementia. Or a frail person may request drugs, such as antibiotics or pain medications, but refuse physical interventions such as CPR. Living wills can also request that the medical staff try all possible treatments, although this is typically the default course of care for patients who lack a living will. The second part of an advance directive is a durable power of attorney for health care, or DPAHC. The DPAHC, or proxy, is a surrogate who can serve on behalf of a patient if the patient is unable to make decisions him or herself. The proxy can fill in gaps in a living will, dealing with contexts, medical conditions and treatments that the patient did not foresee in the living will. It's very important to have conversations with one's proxy. He or she needs to be informed about the types of care the patient would and would not want. In 1990, Congress passed the Patient Self-Determination Act, a law that requires all Medicare and Medicaid-funded facilities, such as hospitals, nursing homes, hospice agencies, home health agencies, and health maintenance organizations, or HMOs, to provide patients with written information on advance directives at the time of enrollment. However, many healthcare facilities fulfill their obligation in a pro forma fashion, such that patients are not fully informed about their rights. In 2009, initial formulations of the Affordable Care Act included provisions to incentivize more thorough efforts by extending Medicare reimbursement to doctors who discussed end-of-life care with their patients. Conservative pundits quickly linked this measure to abortion, euthanasia, and the practice of killing disabled persons in Nazi Germany, and the provision was ultimately excluded from the final bill. But, as I have described, doctor-patient conversations about end-of-life are in no way death panels, and the need for Medicare coverage of end-of-life conversations is ever increasing. With the aging of the baby boomers, 10,000 Americans will turn 65 every day through 2030. Medicare, the primary source of health insurance for 98% of older Americans, needs to be proactive about end-of-life care. In July of 2015, Medicare again proposed to reimburse doctors for end-of-life discussions with patients. Following a 60-day period for public comment and/or congressional action, the proposal will become law on November 1, 2015, and reimbursements will begin in January of 2016. As I said earlier, be sure to check with lawyers and healthcare providers for updates regarding public policy and the law. Dying in America today can be the end result of a protracted, painful, and traumatic experience. And that's unfortunate because we possess the know-how to make most deaths comfortable and even meaningful. Patients have the right to use advanced care plans as a tool to make more probable a death that is consistent with their values and preferences. Lawyers, healthcare providers, and other practitioners and clinicians have a responsibility to make advanced care planning easy and effective.